Thanks, Sakshi. Good afternoon, everyone. Uh, so this is the topic that has been assigned to me. Uh, when you compare tubulointerstitial disease with glomerular diseases and other diseases, this is a pretty dry topic with not much guidelines to follow. I'll try my best to make it as interactive and as helpful as possible. So, a brief introduction on what is the renal interstitium. So, interstitium is actually the fractional volume in the cortex, which is about 5 to 7% by mass and tends to increase with age. So, the interstitium, mainly the cortical interstitium and the medullary interstitium is there. So, that fraction increases with the age. So, the interstitium, as you know, that interstitium has the tubules also. So both of them work in harmony in the electrolyte and acid base balance, the medication and toxic secretion, hormone production, and the repair. So between the vascular pole, the macular dense and afferent arterioles are fibrillar pericytes, which help in the autoregulation. And the proximal tubular cells are the cells that produce the various growth factors and the cytokines. So the PCT is important because it directly interacts with the other two interstitial components through juxtacrine and paracrine mechanisms. So the other cells, the main cells in the interstitium are the macrophages. You have the dendritic cells also, which are basically the antigen presenting cells. We have the lymphatics, the endothelial cells, the mast cells. So the interstitial macrophages, they basically originated from the circulating monocytes that have migrated into the kidneys, especially in the various forms of injury. So mainly there are two different types class-wise, M1 and M2. So depending upon which phenotype is more, there will be more of fibrosis or less of fibrosis or more of reparative process that happens in the kidney. So the balance between M1 and M2 and the interaction with the cells, that is lymphocytes, fibroblasts, and dendritic cells, which obviously occurs via growth factors and cytokines, causes something called as IFTA. IFTA, if you have seen renal biopsy reports, it is the interstitial fibrosis and tubular atrophy, and which causes the chronic tubular interstitial disease. So this is just a brief info on the interstitium as such. So this is the renal dendritic cells, which are CXCR3 positive cells in the basically the green ones, which are surrounding the tubular segments in the medulla of a mice, which is a 3D reconstructed image. So in the first image is what you see as a normal interstitium. You can see the tubules are back to back and the red blood cells are there. You can see the pericytes, which are close to the blood vessels and the tubules. Whereas in IFTA, you see a lot of brown. That's a lot of interstitial fibrosis and a lot of increase in number of fibroblast tissues. If you see these blue cells, which has increased significantly compared to the previous cells. As you know that there are blood vessels known as peritubular capillaries, which is close to the tubules, which also help in produce the EPO or the erythropoietin, which is also a part of the one of the functions of the interstitium. So especially in later in my talk, when I talk about the different manifestations of clinical manifestations of in interstitial diseases, anemia is a predominant factor. So the reason is the EPO producing fibroblasts are affected. So the mechanisms are predominantly immune as well as non-immune mediated. The inflammatory process of injury of the interstitium is by innate and adaptive immune processes, followed by glomerular injury, including downstream effects from proteinuria and other injury pathways. So a glomerular disease can also, because of the proteinuria and also the other toxins that are produced, eventually end up causing tubular damage. Whereas if you see tubulointerstitial disease like acute interstitial nephritis or chronic tubulointerstitial disease per se, they also can have secondary glomerular damage, although less comparatively, but over a course of time. Now, this is a exhaustive list of drugs and medications which are associated with tubulointerstitial disease. So you have the antibiotics, which are most common, beta-lactams, alpha drugs, vancomycin, rifampicin, the anti-cancer drugs, especially the immune checkpoint inhibitors, which are notorious for causing acute interstitial nephritis, especially after many months of starting. and anti-seizure medicines. In fact, all any drug that you can take can has a potential to cause it. I'll focus on the specific drugs which later on in my talk. So how is it different from GN? So hypertension is less common, although can occur in later stage of CKD. Daily protein excretion is usually less than 1.5 gram per day. All these are just by rule of thumb, but it could vary in some cases. Urinary sediments are usually bland and they have few white and red blood cells are there. Although RBC casts are usually atypical for tubulointerstitial diseases, anemia is disproportionately severe for the same GFR due to damage to the EPO producing cells. Sodium wasting occurs although mild with normal anion gap metabolic acidosis with from proximal RTA with or without Fanconi syndrome and from type 1 and distal RTA, 4 distal RTA. So renal papillary necrosis is associated with analgesics or acute pyelonephritis or even in severe diabetic patients with papillary necrosis, and kidney stones associated with metabolic or inherited disorders. Nephrogenic diabetes insipidus is another manifestation which is not usually seen in glomerular disorders, so it occurs from drugs, metabolic or genetic disorders. This is just a summary of what are the different features that we see. We can have proximal as well as distal RTAs and the various conditions. I'll try to summarize the important ones because the whole covering everything is not possible. So the ones that we usually see and which are useful in clinical practice, I'll try to talk on them. So coming to the topic of acute interstitial nephritis. So it's usually an immunologically mediated hypersensitivity reaction to an antigen that is classically a drug or an infectious agent. So it usually accounts for 2 to 3% of all the biopsies. So if you biopsy 100 people, around 2 to 3 will have this. And in that, or 10 to 15% or biopsies performed for an unexplained AKI. And in children, the incidence is around 3 to 7% show AIN. And methicillin, which is the initial drug with which this was discovered, so that's the prototype drug. And then we have moved on to beta-lactam, sulfonamides, quinolones, rifampicin, NSAIDs. So these are all just a small list of drugs of the whole exhaustive list of the other drugs that I talked about, which have implications in AIN. NSAIDs are important because they have a nephrotic syndrome presentation also. Unlike the other drugs, and it can have it can occur after many months also. So the newer molecules are the programmed cell death ligands, especially that used in hematology, and CTLA4 inhibitors. So the immune mechanisms can be both cell mediated as well as antibody mediated. So as I mentioned, there are the MSC class 2 molecules, which are the antigen presenting cells which present the processed antigen to the T lymphocytes, which undergo class change to T1 and T2 lymphocytes. And subsequently, they produce neutrophils and macrophages. And they cause basically CD8 mediated damage to the tubule. So tubulitis is a feature of acute interstitial nephritis. At the same time, there is also antibody production with the help of Th2 mediated Th2 mediated cells, and eosinophils are also produced. So, and once antibody mediated production is there, complements are activated, which will further accentuate the whole process. Although antibodies, when we do a biopsy, may not be seen in the immunofluorescence pattern, but cell mediated immunity is more responsible to acute interstitial nephritis. The reason being, if you see biopsies, you can see a lot of granulomas, which are usually because of cell-mediated immunity as opposed to antibody-mediated. So, although in some cases like anti-TBM nephritis, which is a disorder which can cause acute interstitial nephritis, antibodies can be seen. Otherwise, usually it's a cell-mediated mechanism that predominantly functions. So, coming to drug-related, so usually previously infections used to be more common in causing AIN. Then we started giving drugs, and then infections, superseded by the drugs which we use. So basically, you cause the injury a few days to weeks after the inciting drug has been started. Although cases have occurred months after initial exposure to the drug. So usually patients have sudden impairment in renal function with mild proteinuria, as I mentioned. So these symptoms are usually a dictum similar to all the patients who usually present with AIN. There's not much, except for the nephrotic syndrome caused by NSAIDs, more or less the symptoms are the same. And but flank pain because of the distension of the renal capsule. If you do an ultrasound, you will get bilateral bulky kidneys, usually in acute interstitial nephritis. And so that because of the distension of the renal capsule, there is pain. And that is usually seen in a third of the patients. And sometimes extrarenal symptoms, which suggest a hypersensitivity prototype, are also seen, like low-grade fever, rash, arthralgias, and eosinophilias in about less than 50% of patients. And serum Ig levels may or may not be elevated. So the drugs responsible for acute interstitial nephritis, the ones mentioned in bold are the ones that are commonly seen and cause. And the ones that have the blue asterisks are the ones that cause granulomatous acute interstitial nephritis. So the ones that we commonly use, like ampicillin, benzyl penicillin, rifampicin, sulfonamides, these are the ones that cause these symptoms. So specific drug associations, as we have evolved in the topic of acute interstitial nephritis, there have been prototypical drugs which have been important along the way, especially phenindione. Although we may not be using it regularly now, so that was associated with the development of hepatitis, which can be fatal. Allopurinol also induces AIN, which appears to occur predominantly in patients with CKD and associated with liver and rash with manifestations of Stevens-Johnson syndrome. An AIN caused by NSAIDs is usually associated with nephrotic syndrome in about 3/4 of patients. So it's usually seen in age more than 50 years, and half the cases have been reported with phenoprofen. So rifampicin, this is an important drug because we use it very frequently in patients with TB and also some other disorders also. So AIN can occur in two patterns. So in most cases, it occurs after re-administration of rifampicin, in which case there will be a prior exposure. The biopsy will show tubular injury with interstitial inflammatory infiltrates. Immunofluorescence pattern will show negative complement deposition and immunoglobulin deposition in most cases. Although anti-rifampicin antibodies have been detected in the serum of patients, it may not be seen at the time of renal biopsy, and even an IF can be negative for antibodies also. Whereas in some cases, it can develop after continuous administration of rifampicin for 1 to 10 weeks. However, extrarenal symptoms or anti-rifampicin antibodies are absent, and renal biopsy can show severe interstitial infiltrates, but few tubular lesions in such cases. So this is just a predominant manifestation in acute interstitial nephritis. So renal failure, it's more than 90%, and you have more than 50% in patients having mild proteinuria, pyuria, and hematuria. So these are the predominant symptoms that we see. Eosinophilia, not so much, and extrarenal symptoms in only the prototypical drugs which cause AIN. So clinical presentation of AIN and nephrotic syndrome with NSAID use. So here, NSAIDs, as I mentioned before, mainly in age more than 50 years. So they have presentation with edema. And in such patients, if you do a biopsy, the light microscope will show normal glomeruli. There will be acute interstitial nephritis with everything to point towards minimal change disease, and you will start steroids for the patient. May not need as much as a minimal change disease, although stopping the drug also might help to decrease the disease. And but such patients also may need maybe 0.5 to 1 mg per kg of steroids for decreasing the symptoms. So the pathology is basically the presence of inflammatory infiltrates within the interstitium. They're patchy and predominantly seen in the deep cortex and outer medulla, although can be diffuse in severe cases. So it's composed mainly of T cells and monocytes. However, plasma cells, eosinophils, these are basically the antibody phenotype. Plasma cells, eosinophils, and few neutrophilic granulocytes may also be present. So interstitial infiltrates are always associated with interstitial edema. So usually you see back-to-back tubules when you do a normal, when you see a normal section of the interstitium, it will be all back-to-back. Whereas in case of AIN, they'll be all little spaced out with a lot of edema, and which is responsible for separating the tubules. And granulomas, because in some cases it's a hypersensitivity reaction. In some cases, It's because like in diseases like sarcoidosis, in diseases like Mycobacterium tuberculosis causing granuloma. So they can be seen, although not, and some drugs are also predisposed to cause granulomas, and tubulitis because of infiltration of lymphocytes within the tubules. So that is also seen. The linear IgG staining in tubular basement membrane. Any idea where it usually seen? Lupus, yeah. So in lupus, it can be seen. So in lupus, they say that if there's a severe class 3 or a class 4 with a severe acute interstitial nephritis, so the tapering of steroids should be little not so aggressive as opposed to patient not having any AIN features. So it should be little slow taper of steroids, which is warranted. So this is the linear IgG staining in the tubules that you can see in an IF, where the tubules, the basement membrane of the tubules are picking up the stain, whereas not so much in the interstitium as such. So what is the utility of urine eosinophils? How much? Usually anything more than 5% is what they say, but then you can see all the other conditions that are also associated with that eosinophilia, like eosinophiluria. So it's not giving us any much information extra as to it is this drug that is causing. So it's not a very forthcoming investigation to send. So when we get a case of drug-induced AIN, so the first immediate, as when you have ruled out the other causes, pre-renal causes and other possible obstructive causes of AKI, then you find the offending agent and you stop the drug and you wait for the renal improvement and you see a visible improvement in a week, then you stabilize the patient and give supportive treatment. Whereas if you don't see an improvement, then you can subject the patient to a renal biopsy if the patient is willing. And if there is an acute TIN, then you can treat appropriately. So there is this gallium scan that is not done very consistently in patients who don't improve after a week, and in those patients who are not willing for a renal biopsy. So in such patients, gallium scan can be done, wherein basically gallium that 67 isotope is taken by the lactoferrin, which is seen in the interstitium, mainly more in case of drug-induced causes of AIN. Although the sensitivity of this test is very poor, so it's not so much advised to go ahead with this. But if you're not left with any other options, then you might as well do the test and interpret the results appropriately. So if the patient is having a proven case of AIN, then if there is no contraindication to start steroids, the usual recommendation is to give prednisolone 0.5 to 1 mg per kg. Usually we give for around 2 weeks upfront same dose, and then slowly probably taper over 6 weeks. And then if you see improvement renal function is there or not, then if not, then we'll have to think of other drugs. Although the problem with this is that we don't have much RCTs or other data regarding MMF or rituximab or other drugs as opposed to glomerular diseases. So that dearth of knowledge is definitely there. So we have to see cautiously in patients who are not responding to steroids, who might need a second immunosuppression also. So the infectious causes for AIN. So this is just a list of the usual bacteria, virus, and parasites that we usually encounter, which causes AIN. Here we need to know that hantavirus is one virus that can cause interstitial bleeding. So it can cause interstitial infiltrates along with bleeding. Usually we don't see much of bleeding in the interstitium, although in case of some antibody mediated rejection in a transplant setting, bleeding can happen in case of an acute rejection. But usually interstitial bleeding is something which is very atypical, and if that is seen with a patient having a background history of a hantavirus, then we can think of that diagnosis. So here again, mycobacteria and salmonella, they are notorious to cause granulomatous acute interstitial nephritis. So infectious AIN accounts for around 5 to 10% of all the cases of acute interstitial nephritis. It can be secondary to viruses, fungal, parasitic, or bacterial infections. So renal biopsy show mainly neutrophilic infiltrations. Bear in mind that pyelonephritis also will have mainly neutrophils, and IRGN also will have a predominant neutrophilic infiltration. In addition to interstitial edema with interstitial lymphocytic infiltrates classic in AN. So if interstitial damage is extensive, it can progress to tubulointerstitial fibrosis. The infectious agent can cause renal parenchymal inflammation either by direct infection or can be immunologically mediated damage without direct invasion also. So the cornerstone is treatment of the underlying infection. So whether to give immunosuppression or not is always a conundrum. So we usually we try not to immunosuppress such patients. We try to treat the underlying infection, and there's no much data to support the use of steroids also, especially patients who are having infectious AIN. Whereas just to highlight a few things which I already talked about, some bacteria. So pyelonephritis, it can happen in especially secondary to E. coli, staph aureus, and gram-negative bacilli. In addition to the LUTS symptoms, patients will have distal tubal manifestations like impaired urine concentrating ability, hyperkalemia, and salt wasting. The urine can show lymphocytes and or WBC casts. So usually acute pyelonephritis can also coexist with AIN, but usually chronic pyelonephritis has been implicated as a cause of chronic interstitial nephritis, and along with other conditions like reflex nephropathy, obstruction, malakoplakia. So these are the other conditions that cause chronic interstitial nephritis. So Campylobacter and Salmonella, these are just acute fever, febrile illnesses which caused by Salmonella or enteritis caused by Campylobacter jejuni. So because of the nature of the disease, renal injury is almost always initially associated with volume loss from watery stools or fever. So you will have tubular necrosis also if it is volume loss is very severe, along with the interstitial infiltrates. So a lot of tubular cells which are having less sloughing of the microvilli, or the denudation of the top layer of the cells, and also the nuclear orientation will be also different. So those along with the interstitial edema and inflammation can also be seen, especially in case of pre-renal causes like diarrhea and all that. So viruses, HIV is notorious to cause, although predominantly glomerular diseases like HIV, HIV-associated nephropathy, non-collapsing FSGS, minimal change disease, diffuse mesangial hypercellularity, immune complex-mediated disease, and interstitial nephritis. Most of the cases are multifactorial in terms of how it causes interstitial nephritis. So it can happen secondary to, let's say, tenofovir disoproxil that you give that can cause. So usually we say that alafamide is better. Or if patients are having co-infection with tuberculosis and you give heart therapy prior to treating the TB, so patient can have iris in such cases, and that can predispose to interstitial nephritis also. So coming to chronic interstitial nephritis, so any glomerular disease so can injure the tubular interstitium predominantly to mechanisms involving the direct effects of proteinuria and ischemia. So growth factors, like I mentioned before, the proximal tubular cells are implicated in producing the growth factors, and macrophages which are already there in the interstitium. So it's an interplay between these cells which produces factors like PDGF and transforming growth factor beta. So that has a fibroblastic potential. And then the M1, M2 phenotypic transition that also I talked about, like monocytes. So that depending upon which tilt, which balance favors what, so that will be there. So what happens is that once there's a lot of IFTA, there's a lot of peritubular capillary loss. It's called as vascular rarefaction. So that causes decrease in oxygen diffusion, and that causes the interstitium to be hypoxic. So that further damages the glomerulus, and secondarily it can cause glomerular obsolescence also. So glomerulus itself can be shrinkled later on. So this is just a broad outline of all the causes of CIN. You can have toxins, infections, obstruction, immunological ischemia, and crystals. The pathology is non-specific. It's usually characterized by progressive scarring of tubular interstitium with atrophy, macrophages and lymphocytic infiltration along with interstitial fibrosis. Here you don't see much of neutrophils or any other acute cells. So they include tubular cell atrophy or dilatation with IF that is composed of interstitial with interstitial fibrosis. So you have the type 1 and type 2 collagens and mononuclear cells and T cells, and occasionally other cells, neutrophils, eosinophils, and plasma cells. So here the tubules are usually very dilated. So they're very wide in diameter and show marked dilatation with homogeneous scars producing like a thyroid appearance, and it's called as thyroidization. Basically, classically described in case of chronic pyelonephritis. So here you have a lot of periglomerular fibrosis with chronic infiltrates in the interstitium and thyroidization of the tubules. You can see these these bodies, these hyaline-like bodies in the inside the tubules. So the clues to the tubulointerstitial disease. So when you get a patient who is not fitting into the spectrum of glomerular diseases, and you are suspecting, like you have done tests like C3, C4, ANA, ANCA, SPP, urine BJP, everything has come negative, then you are not left with much of an option. You can do a biopsy, you can put him on ARBs, or you can go back and ask him all these histories also possible. So starting from occupational history, so you do ask about heavy metals, batteries and alloys, lead or cadmium. So lead nephropathy, usually patients who are consuming this moonshine liquor and also they'll have usually that. Alcohol, history of moonshine injection, as I mentioned. Social history, Balkan nephropathy is seen along the river Danube. So, and past history of any autoimmune disease. So there's a lot of conditions that can cause, I'll be mentioning about these in subsequently. And the drugs, as I mentioned. And importantly, something known as analgesic nephropathy. Previously, we attributed it to a combination of phenacetin, caffeine, and aspirin. Although nowadays, even paracetamol, if taken in a in a dose which is not acceptable, can also, over a prolonged course of time, can cause analgesic nephropathy. So basically, in such patients, even a radiological examination like decreased volume of the size of the kidneys, bumpy contours, papillary calcification, and microcysts on MRI. So microcysts on MRI are usually seen in metabolic disorders which cause nephropathy, like hypokalemic nephropathy. Lithium can cause microcysts. Tubular vacuolizations can be seen in case of such cases. And nephrocalcinosis on CT. So that can be seen in hypercalcemic nephropathy. Although distal RTS can also cause nephrocalcinosis. So once you have ruled out that, then if patient has hypercalcemia and hypercalcemia, calcemic nephropathy, usually the interstitium will be having a lot of interstitial calcifications. And if you do the von Cosa staining, that will come as black. So that's how you diagnose that. So some of the clinical functional manifestations of CIN. So the deterioration of GFR is with an insidious onset. So it's not like an RPGN presentation. It's a very creeping creatinine that keeps on increasing with not much of a proteinuria and inactive urinary sediment. And like I mentioned, anemia can be there. And patient can have a Fanconi phenotype or without a Fanconi phenotype. So they can have a partial Fanconi also. So they'll have more of aminoaciduria, phosphaturia, proximal renal tubular acidosis, Fanconi syndrome. Distal usually seen in case of Sjogren syndrome. Sometimes it can be the initial presenting symptom also. Medullary dysfunction, concentrating defects, nephrogenic diabetes insipidus, lithium, hypercalcemia, hypokalemic nephropathy. These can all cause medullary dysfunction and and diuresis. So salt wasting syndrome, and this is, so basically it's a salt sensitive hypertension. So what are the major causes of chronic interstitial nephritis? So if you look radiologically, in which kidneys are macroscopically normal, so you have the drugs and toxins, aristolochic acid, which was initially described in China, and lithium, cyclosporin, tacrolimus, all these anti-rejection medicines and immunosuppressants, and metabolic causes like hyperuricemia, heavy metals, radiation, Balkan nephropathy, immune conditions. Then vascular causes also, sometimes transplantation, hematological disorders, progressive glomerular disease, and idiopathic. So sometimes kidneys are macroscopically abnormal. So like I mentioned, they'll have bumpy contours, papillary calcifications, especially in analgesic nephropathy, chronic obstruction. So if it's a obstructive uropathy or a reflex nephropathy, which is causing grade 4 VUR or something that has secondarily caused damage to the kidneys. A kidney size can be shrunken as opposed to the previous causes. And also in cases of AD-PKD and AR-PKD, and infections like chronic pyelonephritis, malakoplakia, xanthogramulomatosis, pyelonephritis. So drug-related CINs. So lithium nephropathy. So lithium is mainly, as you are aware, it's used in the treatment of bipolar disorders. So manifestations mainly include nephrogenic diabetes insipidus. It can also cause an acute lithium intoxication, chronic lithium nephrotoxicity also. So basically enters via the ENaC channels. As you know, it's located in the distal aquaporin 2 channels from localizing toward that to the side of the membrane. So as a result of which there is no reabsorption of water that happens in the distal tubules. So there is a nephrogenic diabetes insipidus. And does the cumulative dose correlate with interstitial fibrosis and further damage? Yes, it does. So this is something that can, so it may not happen with a single dose. It can happen over a prolonged period of time. And the damage can be pretty damaging also, as in cannot um, um, be recoverable also in some cases. So lithium is also a cause of hypercalcemia. So how it happens is because you're having a lot of diuresis, there's increased PCT reabsorption of calcium in the proximal segments. So that can potentiate the tubular concentration defects. So hypercalcemia itself can cause decreased aquaporin channels to be functioning. So that can also worsen the nephrogenic diabetes insipidus. Along with, so if patient is having both, it's not a good combination to have. So it's mainly seen in women more than 60 years. The lithium levels are more than median. So as you know, it has a narrow therapeutic window. So anything more than 1.5, if I remember correctly, it's a mild, moderate, severe. The classification is there. So it's very important to make sure that patient's levels are normal as the creatinine goes on increasing. Can cause irreversible renal damage. There is a huge latency to ESKD, which is approximately around 20 years. So tubular cystic dilatation. So as you can see, this is one glomerulus, and you can see a lot of dilated tubules. Here also, some tubules are having some cystic dilatation. So this is classical seen in case of lithium, especially the proximal tubules are mainly involved. So you can see it in the microscopy as well as even MRI also can show, because sometimes these changes may not be picked up in ultrasound. So lithium nephropathy, amiloride is one thing that can be given. As you know, it will block the ENaC channel, and the entry of lithium to the cell ENaC to the distal cell will be stopped. So it can help. Thiazides should not give, because as you know, it can cause hypercalcemia and help perpetuate the already nephrogenic diabetes insipidus at play. So since it has a narrow therapeutic window, the level should be monitored and maintained between 0.6 to 1.25. So anything less than 1.5 is okay. So this should be 0.6 to 1.25. So dose reduction is the first dictum. You reduce the dose and see whether patient is able to tolerate, and how is the polyuria, especially the nocturia that such patients will be having, is very disconcerting. And if there's not much improvement, renal biopsy can obviously be done. So analgesic nephropathy, this is important, as a lot of historical significance also, as it used to be resulting from a cocktail of analgesics previously, which was used a combination of phenacetin, aspirin, and caffeine. So they were the over-the-counter drugs which are available in Europe and Australia. So the last study in United States showed that there is no association between use of current analgesic preparations and increased risk of chronic renal dysfunction. So mainly classically seen in women around 5 to 7 times more than in men. And it can cause sterile pyuria, papillary necrosis. There's a risk of transitional cell carcinoma in the urothelium over a prolonged period of time. So such patients do need cystoscopy and monitoring if the patient is having a new onset of hematuria, weight loss or something later on. So such patients should be referred to urology. And again, as in lithium nephropathy, the ESKD is around, the latency is around 20 years. So here the pathology is medullary ischemia, which subsequently causes hypoxia. There's inhibition of vasodilatory prostaglandins, and the antioxidant levels in the interstitium are also low, the low glutathione levels, which all cause papillary necrosis. So that causes secondary IFTA. So this is just a non-contrast CT showing papillary necrosis at the tip of the papillae. So differentials would be analgesic, diabetic, and yeah. So some of the systemic diseases that are implicated in chronic interstitial nephritis, mainly Sjogren's syndrome. Bear in mind that these diseases can also cause an acute interstitial nephritis picture also, but I wanted to discuss here because it is more predisposed to cause a chronic type of change rather than an acute change. So such patients, around 5% of patients have renal involvement, and about 3/4 of patients have with Sjogren's syndrome who undergo renal biopsy will have tubulointerstitial nephritis. So usually, as you are all aware, can show hypergammaglobulinemia and hypocomplementemia, as well as severe hypokalemia from distal RTA and tubular dysfunction. So CD4 T lymphocytes, mainly what drives the tubular inflammation. The CD8 lymphocytes also seen plasma cells and granulomas, especially non-caseating granulomas are seen. So immunosuppression therapy, again, not proven. So steroids, there's hardly much evidence, but then like I mentioned in that slide for AIN, we can try with 0.5 to 1 mg per kg of steroids for around 6 weeks and slowly taper and see. Most patients will recover unless there is a concomitant GN also. Sjogren's syndrome can also be associated with something called as cryoglobulinemia glomerulonephritis type 2 and 3. So that will have a nephritic type of presentation. It has nothing to do with this. I'm just telling you the different other manifestation of Sjogren's. It can cause a distal RTA. It can simply present as granulomas without interstitial infiltrates, or just interstitial infiltrates as such, or plainly as a distal artery with only metabolic abnormalities. So you should have a wide range of suspicion as to what exactly is going on when you get a Sjogren's patient. So in a biopsy series of 24 patients with, including 15 with had only TIN lesions, and steroids steroids improved the kidney function. So a recent study showed no benefit of immunosuppression therapy, combination of PRED and MMF, in 6 out of 8 patients with TIN. But SS with TIN have better prognosis with than those with glomerular involvement. So and rarely progress to ESK. Sarcoidosis is another chronic multisystemic non-caseating granulomatous disease. As you know, of the way it causes hypercalcemia, subsequently causing hypercalciuria, as you're all aware of that. So that can in itself cause renal impairment. But as opposed to Sjogren's, granulomatous changes are rare, and labs show AKI, which can be isolated or associated with mild proteinuria or sterile leukocytes in the urine. Treatment with high-dose corticosteroids quickly improves renal function. However, most patients do not recover. Again, there is no guidelines for steroids as such. So how you treat a systemic sarcoid, you can give like that for the renal disease. IgG4 related disease is something that's coming up in a big manner. So there is immune-mediated fibro-inflammatory condition affecting multiple organs, and is characterized by diffuse lymphoplasmacytic infiltration. So clinical manifestations can include ILD, sclerosing cholangitis, RPF with ureteral obstruction, something called as maiden waist deformities, and microvascular manifestations such as large vessel vasculitis. So IgG4 related disease is associated with plasma cell rich tubulointerstitial nephritis and fibrosis. This very closely sometimes can mimic Sjogren's syndrome also. So such patients, there is a rapid steroid response in patients having IgG4 related. If it's a proven IgG4 related disease, I will show you the criteria for diagnosing IgG4 on a renal biopsy. So relapses can occur in the kidney, and rituximab is effective in steroid refractory cases. So here is a histology. Will have predominantly plasma cell rich tubulointerstitial nephritis with more than 10 IgG4 positive cells. In CMC, as far as I understand, we are not doing the IgG subclasses as such. So IgG4 positive plasma cells in the most concentrated field. So tubular basement membrane immune complex deposits by IF or electron microscopy. So you need histology, all should be present, and one each from imaging, serology, and other organ involvement for a diagnosis of this condition. So here in the first image, it's just a H&B stain of renal tissue, which shows a lot of mononuclear cell infiltrates. In fact, IgG4 positive cells, which are seen in that interstitium with widely spaced tubules also. So this is again, these are sheets of plasma cells actually, that is a high power view of plasma cells. And this is again a CT of a patient who had a sausage-shaped pancreas and apparently also had IgG4 disease affecting the kidneys. So you get bilateral bulky pancreas in IgG4. So SLE, as with the glomerular involvement, you can have tubulointerstitial nephritis with or without immune deposition in the TBM. However, histologically, the tubular basement membrane immune deposits, they correlate with the serological activity, but not with the prognosis as such. So in a study by Yu et al. On 313 patients with LN, presence of tubulointerstitial nephritis was significantly associated with doubling of serum creatinine. So this is always a poor prognostic factor. And if you look at the how you stage GN, that activity factor and also that chronicity factor, not much is given importance for the tubulointerstitial aspect as such. So we need, so in a patient who is not responding to normal immunosuppression, we need to probably give more aggressive, maybe pulse the patient, give prolonged course of steroids, slow taper of steroids. So those things should be done as opposed to a patient who's having class 3 with a normal creat and subnephrotic proteinuria. So this is not a good prognostic factor to have if it is a severe TIM. So here again, you can see that it's an H&E stain, which is showing a lot of tubulointerstitial infiltrates with monocytes and somewhat widely spaced tubules. So this is again an IF which showing IgG deposits in the tubular basement membranes. So IBD, as you see, can also be associated with tubulointerstitial nephritis, which is a common renal manifestation. A biopsy series of adults with TIN, it was seen about in 19%. Among those, 44 were acute and 31 had granulomas and 25 were chronic. So 5 ASA and derivatives, sulfasalazine, mesalamine were predominant causes of TIN. And tubular proteins as markers of disease activity have been studied, although none has been validated. So tubulointerstitial nephritis and uveitis. So TINU was initially described by Dauberin et al. In 1975 in 2 adolescent girls with interstitial nephritis and anterior uveitis. The risk factors are young women and sorry, the age is 20, not 76. And HLA is association is DQ and DR associations are present. And TINU considered where tubulointerstitial nephritis and anterior uveitis occur concomitantly without other systemic diseases. So ocular symptoms are independent of kidney disease and prognosis is favorable. So here there is a proven role of steroids, wherein here we have, this is a study that was done in a French nephrology pediatric center from 2008 to 2018 on 58 females. 52% females and median age was around 13.8. So the baseline EFR at the beginning of the diagnosis was around 30 and they were all given steroids. 44 out of 46 received steroids and their median GFR at follow-up had significantly improved. So the dictum is that all patients who are presenting with tubulointerstitial nephritis should undergo systemic ophthalmological screening also in even the absence of ocular symptoms. So to Mycobacterium tuberculosis, I wanted to include in the chronic interstitial nephritis part because here you have all sorts of manifestations. So about a quarter of patients present with extrapulmonary TB, if you look at the whole number of TB patients, and in that 15 to 20% of non-pulmonary infections are in the GIT, in the genitourinary tract, the second most common site, and only 4% have isolated genitourinary TB. So classic presentations include sterile pyuria, pelvic axial deformities, and scarring and calcification, and occasionally reduced GFR. So chronic tubular interstitial nephritis with granulomatosis is another important and often misdiagnosed type of degenerative urinary TB. And the kidney biopsy should be especially low in patients who are having TB and HIV, because such patients can have underlying granuloma and AIN also. So we should treat such patients at the earliest with steroids. So here, this is basically a granuloma in the interstitium, which is having some epithelioid cells also. Although it's usually caseating in tuberculosis, here it's a non-caseating granuloma that has been described. So Mycobacterium tuberculosis, the diagnosis is of TIN, and early treatment of the ATT and steroids may help preserve the renal function and delay the onset of RRT. However, the role of steroids, as you know, in most cases, needs further RCTs and further studies. So metabolic disorders is another huge chunk of chronic interstitial nephritis causes. So first would be chronic uric acid nephropathy. So in uric acid nephropathy, so historically there is medullary deposition of crystals with surrounding inflammation and fibrosis. Anyone can tell the difference between urate nephropathy and uric acid nephropathy? Both are not similar. Urate nephropathy is different from uric acid nephropathy. Urate nephropathy usually in tumor lysis syndrome, when you get when you give chemo, in such patients you will have intratubular obstructions because of that uric acid crystals. So that is called as urate nephropathy. It's not same as uric acid. So here you have medullary deposition in the interstitium, the surrounding inflammation and fibrosis. So usually such patients have coexistent hypertension, vascular disease, and aging associated renal injury. So RAS is inevitably activated, resulting in glomerular hypertension and impaired autoregulation. So, so there is a pro-oxidant versus antioxidant theory that is floating around. So here, in cases of uric acid nephropathy, the interstitial, as you know, has a lot of glutathione and other antioxidants. So there is a slight tilt towards the pro-oxidant condition. So that is also attributing towards this. So such patients have phenotype of hypertension, minimal proteinuria, bland urine, minor tubular dysfunction. So whether or not to treat this is one question. So, so usually such patients, we control the hypertension, we control the, if patient is having symptomatic hyperuricemia, we treat the patient asymptomatic. Occasionally we treat, although some guidelines don't mention it to treat. Whereas if it's above more than 10, usually we treat such patients, even if patients are not symptomatic. Because uric acid, if you read the literature, has a propensity to cause CKD in the long run. So it is better to treat, although some clinicians, they don't treat it. So here in the pathogenesis, we can see that it can cause, it has a pro-oxidant phenotype, uric acid. So they can cause endothelial dysfunction, inflammation, oxidative stress, activation of RAS. So all eventually ending up in hypertension and progressive renal disease. Hypokalemic nephropathy is so this disorder is not seen in a case of acute hypokalemia or something. It's something that's seen in chronic conditions, any condition that can cause chronic hypokalemia. Sometimes it can be even anorexia nervosa with binge vomiting and like binge eating and vomiting. So such patients can have this symptom. So, so basically they have prolonged periods of hypokalemia, which causes renal cysts. And so slightly bigger cysts as opposed to the lithium, where you get a little microcystic tubular dilatation. And you have chronic interstitial nephritis and progressive loss in such patients. You have coexistent hypertension, vascular disease, and aging, and vacuolization of renal tubules, which basically occur due to the dilation of the cisterna of the endoplasmic reticulum, and basal folding. That is again limited to the proximal segments. So prolonged hypokalemia can cause permanent damage. It can also cause ADH in under responsiveness, again causing nephrogenic diabetes insipidus. So impaired voting, urine concentration, nocturia, polyuria, polydipsia. And most of the studies have shown that potassium concentration has to be less than 3 for many years or months to cause this. Usually associated with decreased collecting tubule response variant is vasopressin because of decreased response to aquaporin 2. And average duration is around 3.5 to 9 years to cause this disorder. So you treat the underlying condition and treat hypokalemia, and that's the treatment here. So hypercalcemia, due to whatever cause that led to it, whether it's malignancy, hypothyroidism, can cause a transient and reversible renal vasoconstriction. That is in the acute setting. And prolonged hypercalcemia and hypercalciuria can cause nephrocalcinosis and chronic interstitial nephritis with interstitial calcifications in the being present. So light microscopy LM can show tubular and interstitial calcifications accompanied by lymphocyte predominant interstitial infiltrates and fibrosis. So here is a von Cosa staining, which is showing predominantly the stain picks up black color, which is a lot of calcium deposits in the interstitium. Here it's an HND stain, which causes a lot of blue aggregates which are seen in the interstitium. Again, showing the tubular infiltrates, interstitial infiltrates, and lymphocytes. The heavy metals is another important, under-recognized, often overlooked area uh, which can cause CIN. Although in our routine practice, we don't send a lot of patients for heavy metal screening if we get a diagnosis of CIN on the biopsy. Although, but it should be done, especially in those cohorts where patients are having an occupational hazard or something that can possibly cause it. So lead is implicated as something that can cause an acute toxicity, which can manifest as an abdominal pain, encephalopathy, hemolytic anemia, peripheral neuropathy, and proximal tubular dysfunction. So the biological half-life is of several decades. So even if you take it, it can remain in your system for a long time. So some epidemiological studies suggest that low-level exposure may be associated with hypertension and CKD. These are all epidemiological studies. And the kidneys are granular and contracted. And the earliest histological finding is proximal tubular injury with intranuclear inclusion bodies composed of a lead protein complex, which is usually again seen in the proximal tubule. So here hyperuricemia is also very commonly seen because lead inhibits the excretion of uric acid. So as a result of which hyperuricemia is seen. Urine sediment is usually benign and urine protein excretion is again in the tubular range with less than 2 grams per day. Hypertension is usually seen since you know that uric acid can contribute, although in a small manner, to hypertension. And even otherwise, lead nephropathy has been shown to cause hypertension. Saturnine gout is something that that usually we associated with gout with monosodium uric crystals, but this is something that can lead uric acid lead itself is getting deposited. That is something causing gouty presentation. So it should be one of the differentials in patients who are having kidney injury and a gout presentation. So high index of suspicion in patients who are having high uric acid levels, hypertension, and renal impairment. So calcium sodium disodium EDTA is a diagnostic as well as a therapeutic test, which basically 0.5 gram of calcium disodium EDTA given twice for the patient, and the urine is collected over the next 3 days because lead has a very small rate of excretion via the urine. So if it is less than 650 microgram in 3 days, it's normal. Anything more than that is suggestive of lead nephropathy, although a biopsy can also prove it. But this is a non-invasive test which can give a diagnostic value as well as a therapeutic value also. So CKDu is something which is already destined to cover in the next few weeks for you, but I will just like to highlight few important concepts regarding CKDu, which is a evolving form of CKD, basically of unknown etiology, prevalent mainly in the certain rural populations and around the world. So global prevalence was around 275.9 million in 2016, disproportionately higher in lower and middle income countries. and compared to high income developed countries. The other names are CKD of non-traditional etiology, constant interstitial nephritis in agricultural communities, or otherwise known as CNAC, CINAC, or kidney illness of unknown reason in horticultural workers. Usually seen in low income tropical, subtropical areas in rural and middle-aged men working in agriculture and similar work requiring hard manual labor. This is just a outline of how patients are predisposed. So usually patients have dehydration along with heat stress, which can cause exertional rhabdomyolysis, causing urate production, which also causes RAS activation. Dehydration itself can cause RAS activation, and that eventually increases the vasopressin levels. Then fructose pathway is also activated, which perpetuates the vasopressin increase, eventually causing ischemia, glomerular dysfunction, glomerular hypertension, oxidative stress, tubulointerstitial damage. So the pesticides, especially organophosphorus pesticides, have an unproven role in causing CKDu, although it has been, in some cases, the association has been made, along with NSAIDs, nephrotoxins, heavy metals, in a population which is predominantly in the rural setting, with farmers mainly being affected. So this is just a list of conditions that the cause that encompasses this condition. Basically, Ita nephropathy is basically because of cadmium deposition in the body. Balkan nephropathy is seen in near the river Danube. Aristolochic acid is a compound that was used in China that also caused nephropathy. Sri Lankan nephropathy, Mesoamerican, and Udanam, which is a district in Andhra Pradesh. I'll talk about that. So CKDu in India, which is first case was reported in Udanam in AP, and disease is seen in hot rural areas where farmers grow coconuts and cashew nuts and rice. Trace elements, silica and strontium have also been implicated. So such patients usually have a normal blood pressure, as in most cases of CIN, and low or no proteinuria with nothing to show in the urine, and and renal biopsy showing chronic interstitial disease with variable glomerulosclerosis. So proposed criteria for CKDu in India, this is the mandatory criteria with EGFR less than 60 and or 1 plus proteinuria, and you have exclusion criteria as mentioned. Although the criteria for a definite case would be, it's mainly a diagnosis of exclusion. So you have to exclude all these criteria. Patients having diabetes with all the HbA1c cutoffs all ruled out, and BP also should be ruled out. And CKDs because of ultrasound, documented by ultrasound, and renal disease secondary to a certain cause like obstruction pathology, vasculitis, lupus, all should be ruled out with no proteinuria or minimal red cells in the urine, along with kidney showing shrunken kidneys and kidney biopsy specific of tubulointerstitial nephritis in the absence of immune deposits. The management is usually we do a biopsy, although there's nothing in the biopsy that you would point towards this. So it's more of a clinical judgment. And although some lab tests can point towards it, like urine tests, serum creatinine, sodium, potassium, magnesium, uric acid, and creatine kinase, which can be high if patients having rhabdomyolysis. Some detailed occupation and environmental history, like physical labor in hot environment, like infectious agents like malaria, lepto, and pesticides have all been implicated. So if such patients are, if a person is coming from such an environment and is found to have this, so we should advise such patients to restrict from performing heavy labor and other such work. So treatment is usually supportive, although to give RAS or not is one question. So such patients are usually volume depleted. So RAS would not be a good good thing to give. In such patients, they'll have low to normal BP. So since hyperuricemia is common in affected patients, some studies shows that allopurinol may provide some effect against heat-induced stress injury. Clinical trials are also need of the hour to determine whether uric acid lowering drugs will cause any beneficial in such patients. A brief idea also about on cystic disease of the kidney, although it's a separate topic as such, but it's important to know some diseases, as we see ADPKD a lot in our OPD. So this is just a brief outline of patients who present with cyst on ultrasound. So when you get a patient with cyst with a family history of ADPKD, then if it's a known genotype, then you don't need to do a genetic testing as such. Then you have the ultrasound as well as the MRI criteria to diagnose whether it's ADPKD or not. And once you have ruled out all these things, then you come to the other important cystic diseases. So you have the ADPLD, the other autosomal dominant polycystic liver disease, the ARPKD, although not seen usually in our OPDs or maybe in the pediatric age group. Tuberous sclerosis, von Hippel-Lindau. ADTKD is another important cause of autosomal dominant tubulointerstitial kidney disease, which has MUC1 mucin gene mutation, UMOD gene, that is a uromodulin gene mutation. All these are genes which are involved in producing the TAM phosphol protein and other things which are in the tubulointerstitium. So if they are getting affected, they can cause corticomedullary cysts, progressive CKD, small kidneys, gout. And something which can present in diabetic patients is renal cyst, diabetes, hypomagnesemia, genital malformations, and gout. If you have such a phenotype, then you should consider ADTKD, HNF1 beta prototype. So even in CKD per se, patients can have cyst. So if we don't know what is the cause of cyst in the kidney biopsy, not biopsiable kidneys because of low thin cortex or presence of cyst. So CKD stage 4 and 5, anything less, EGFR usually less than 20, such patients can have acquired renal cystic disorders. So such patients have a potential to have malignant transformation also later on. So screening is also required. In such cases. Sometimes if the patient is going for transplant later on, that native kidney can have a cyst and can have a tumor also. So we should not overlook such findings. So ADPKD, few words on ADPKD. So just a multisystemic disorder with bilateral renal cyst. You can have other cysts in liver, pancreas, and anechoic membranes also. It's an autosomal dominant disease. PKD1, PKD2 gene mutation. GANAB is one another mutation that is predominantly involved in ADPLD. Animal models and analysis of cystic epithelia show that renal cysts develop by a loss of functional polycystine and with somatic inactivation of the normal allele. So genetics is mainly PKD1 and PKD2. So they are basically, their function is to move from the endoplasmic reticulum to cilia as a complex with polycystine. So I'll explain that in a diagram. So this is basically all the signaling pathways in PKD1. So you have basically less than 5% of the tubules that are affected in ADPKD, and they are filled with fluids. So that fluid secretion happens because this CFTR gene is activated, and that is activated because there's reduced, you can see there is PC2 and PC1, they're not functioning properly. So there's no calcium efflux from this PC2. And as a result of which SST, that is somatostatin receptors, and there's a aquaporin receptors also on the basolateral side of the tubular cells. So those are not getting inhibited. So there is a lot of secondary messengers that are produced like cyclic AMP, protein kinase A. So that will subsequently cause CFTR gene proliferation and calcium efflux causing fluid secretion and cell proliferation. So ADPKD, as you know, cysts are one thing, but the pressure effect on the kidney, on the normal parenchyma is another thing that can cause pressure effects as well as bleeding also, hematuria, sometimes malignant transformation later on. So cystogenesis happens only in 5% of kidneys. Epithelial cysts develop from pre-existing renal tubules and composed of layer of partially dedifferentiated epithelial cells enclosing either urine or semi-solid material. So the clinical manifestation is asymptomatic until the 4th to 5th decade of life and are diagnosed by incidental discovery. So pain in the abdomen, flank, or back is the most common initial complaint and can cause can happen from rhinomegaly, cyst infection, hemorrhage, nephrolithiasis, or tumor. Visible hematuria is seen around in 40% of patients. And this is the list of all the conditions that can you can have pancreatic cyst, prolapse of the MVP, pericardial effusions, diverticulosis, intracranial aneurysms, and there's a lot of screening that also needs to be done. I won't go into all of that. So mainly to diagnose it in an OPD setting would be to have patients who are having, especially if this age group fits in, we have to have a total of more than 3 cysts combined right and left kidneys if the age group is between 15 to 39. The negative predictive value, especially if patient is having like if there's a negative family history, then for diagnosing ADPKD age, if less than 60 should have at least 5 cysts bilaterally, or if more than 60 should have 8 cysts bilaterally. CT scan is another sensitive test that can detect very small cysts also, usually useful in children and uncomplicated cases of renal stones and suspected tumors. So, but it exposes the patient to radiation and expensive height. HTTKV is basically height adjusted total kidney volume in ADPKD patients. So whether to use tolvaptan or not. So if the total kidney volume is more than 16.5, the patient's age is more than 55 years. If there's a rapid fall in GFR, we can use a drug called tolvaptan, which is basically a aquaporin 2 receptor antagonist. So that has been shown to in multiple trials like TEMPO and reprise trials to decrease the cyst growth. Although upfront we will advise the patients to drink more water, around 3 to 4 liters, to suppress the ADH production, and also ARBs. So this is the dictum. So this is just a CT showing multiple cysts in both sides of the kidney, and subsequent B image is after infusion of iodinated radio contrast. So contrast enhancement highlights the functional parenchyma, which here is concentrated primarily in the right kidney. So you can see the functional parenchyma is mainly in the right kidney in this image. The polycystic kidney, this is the brief outline of all the trials. So initially there was, the important ones are the HALT A and HALT B PKD trials, whereas low showed that the lower BP goals did not, low BP goals led to a lower increase in kidney volume, HALT A trial, whereas HALT B did not show much difference between the two. TEMPO and reprise were positive trials which showed importance of tolvaptan compared to placebo in decreasing ADPKD symptoms. So mainly the take-home points I wanted to give you were that there is an important set of disorders but hugely overlooked because as cause of renal dysfunction, because so many disorders are under spray, and KDIGO guidelines are also lacking. If you go to the website, you can see almost all guidelines for transplant, CKD, and ADPKD, but there's nothing on this. And potentially treatable causes upfront if diagnosed early and managed astutely. So there's a dearth of trials also that unfortunately is a limitation. So low threshold for biopsy and good history will help us to diagnose most of the CIN cases and ruling out other causes. Thank you.
Thank you, Dr. Vinay, for that complex lecture broken down into a simplified way. Any questions from the audience?
Sir, young patient with prior normal renal function admitted with salmonella type infection having AGE, and during the time on arrival he is clinically dehydrated having pre-renal AK like urea of 120, creatinine somewhere around 6. For some patients, upon giving hydration, either the creatinine value is not normalizing or in other way it's rising. So in this patient, how to treat this individual? Do we need to take this as ATN because urinal is showing kind of bland to no massive proteinuria? Okay. Like how you
mean
describe...
it's not fluid responsive initially when patient comes?
Yes, sir.
Not fluid responsive. Then you can give a diuretic challenge and see based on 1 mg per kg body weight and see if it is just a initial ATN which might, you can pull off the patients from going into dialysis. That is a recommended. It's actually 1.5 mg per kg in furosemide naive patients and 1 mg per kg in other patients. So that is one thing you can give. And AIN won't be the first differential when such a patient comes. You will think of, like you mentioned, pre-renal causes only. So that you treat obstruction, also you rule out other causes, you rule out stones. Imaging becomes important in such cases. You cautiously hydrate the patient, give diuretic, and see how much is improvement is there. And creatinine is a very dynamic structure, dynamic value. Ideally, EGFR estimation is not good when you suddenly patient comes in AKI. So there are no, whatever formula that we're using is not specifically for that. The CKD EPI equation is not for that that acute setting, basically. It's a dynamic setting. So kinetic EGFR is another one that they've said which can give you or how much how has been the trend. If you have some values that can also help us in guiding. So
sir, the doubt is not at the presentation, sir. At the end of discharge, 1 week patient clinically improved, hydration is okay, but the creatine is not improving.
Okay.
But in terms of some cases, the creatine is rising, or that 7 is not coming to the baseline, touching at 4. They are having prior normal creatine like 0.8 something.
Okay.
So in that case, why the creatine is not coming down?
Then one possible is like the drugs that can be you gave for the treatment of salmonella, that itself can possibly. So AIN has to be significantly up on the list. Second thing is something which is not related to the drugs or the disease as such. Something called as renal vein thrombosis. That is not related to any of this. So those are also causes for non-improving renal functions because patient is dehydrated. Patient can have other causes of not improving creatinine also. So you have to rule out such cases, such things also. Renal vein thrombosis has to be ruled out. Patient can be hypoalbuminic also. So that can predispose to the AKI. So I won't biopsy at that point of time if that's your doubt. So I'll probably wait for maximum maybe 2 weeks. Although this guideline says 1 week, but that is if you have completely ruled out all the other causes, then you can go out for a biopsy. But we feel that we have already treated with the patient some whatever drug that you have given, if it's AZI or antibiotic, that itself can cause granulomas. So if you stop that drug and see if you see creatinine decreasing, and if you have ruled out, let's say, renal vein thrombosis or other things, then probably you can go for biopsy. So it won't be a initial management. Yeah.
One question that is online. When do we decide to start steroids in AIN? And how long should we wait for spontaneous resolution before starting steroids?
Okay. So that's a good question. So as per the guidelines, you can wait for around 1 week. But in our clinical practice, usually we wait for 4 to 6 weeks sometimes because if it's a resolving AKI, ATIN, we even wait for 6 weeks sometimes. Sometimes it's a 2 weeks. So it's case per case. So if there's an obvious cause of disease that is predisposing to this, then we treat the cause. Then we won't push for a biopsy. So, and to give treatment as such, sometimes it will be 0.5 mg per kg, sometimes it will be 1 mg per kg. But whether to taper soon or not, depending on the underlying condition, like Sjogren's autoimmune diseases, you won't taper it fast. You will give a slow baseline immunosuppression ongoing. But if it is just a drug-induced AIN, let's say some NSAID has caused AIN, then you can probably taper it over a course of 6 weeks. 2 weeks upfront full dose, and then slowly taper over the next 4 weeks. So again, there's no standard guideline as such to how much exactly to give. So, and the second immunosuppression is another thing which also is lacking, MMF or rituximab.
There's another question regarding that. How long to treat AIN with steroids before switching to other drugs? And for a mission hospital setting, what drugs can be considered as options?
So see that again, the lack of trials is not helpful in this setting. So we don't have much evidence to say even azathioprine or MMF can help. So steroids is the cheapest option that is available, provided patient is not having any psychosis or any other diabetes or uncontrolled sugar. So in such setting, we can give for minimum of 6 weeks. Don't repeat tests in between. Might as well give for 6 weeks upfront, and then you can do the test and see. So if that's not an option, then can try AZA or MMF. But again, there's no much, because if there are granulomas in the biopsy, then you have to immunosuppress the patient, and because it's suggestive of a T cell immunity based of like that particular finding. So better to give immunosuppression for 6 weeks. There's no incentive for giving a prolonged course of steroids like you give in MN or something like that for 6 months or something. There's no guidelines to second that also. So mainly 6 weeks is what they say.
Thank you so much, Dr. Vinay. Thank you for the lecture. Please fill the post-test link that will be given online soon. And please join us for lunch. Thank you all for coming.